So in terms of the weight history, you've got this in your handout. Basically, it shows how much weight they'd lost, what had happened during the last 2 weeks. Their intake, about a third of them were taking in the past month less than usual. About half of them said there was no change in what they'd been taking in the last month. And about 12% said increased. Now, what would be the reason people say increased?
Stress.
I'm sorry? Stress? Yeah, you're nervous, you're anxious, you eat more. The other thing, certainly having a cancer diagnosis can make people anxious. We know that about 50% of women with breast cancer actually gain weight during their treatment, so it could include those. And also some people may be on corticosteroids, they eat more. They're not necessarily eating the protein that they need, but they may be eating more. And maybe some of those people saw a dietitian and now we're eating more because the dietitian had told them. So there can be a lot of different reasons in this. But I think one of the most enlightening components was the fact of when patients checked off that unchanged, 16% of those who had checked off unchanged as a subcomponent, it said they were taking very little of anything. So sometimes when we ask our patients, has your appetite changed? Are you taking about the same food or less? Or is it unchanged? They'll say, oh no, it's kind of what it's been for a long time. Well, what that means is that 65 or 70-year-old gentleman who has his intake unchanged, it just means he's been taking poorly for a long period of time. So it's also interesting, of the people who said that they were taking less than usual, a quarter of them also said they were taking very little of anything. And when you actually get down to what they're taking, it is that way. In terms of nutrition impact symptoms, remember that SGA originally did mainly components of GI symptoms, but we actually then put a number of other ones that would be common. We've added others subsequent to that. But these are all things that have an impact. If I'm constipated, I'm not going to eat. Okay? If I have dry mouth, I'm not going to eat as well. So those were our nutrition. But what you see is almost 60% said they had no problems eating. Does that go with what you think about your patients who have cancer or who are losing weight? That doesn't even make sense. So what we then looked at is the fact that there were a lot of people who were saying they were having no problems eating, but they had a lot of nutrition impact symptoms. You know, up to almost, here we've got 6.5% had dry mouth. Almost 5% had constipation or diarrhea. Pain, taste or smell changes. So when a patient says, I'm not having problems eating, lots of times what they mean is, I can chew it, I can swallow it, it goes down, it stays down, and it doesn't come out too fast. That's what they mean by not having problems eating. Now clearly the people who say they are having problems eating have a much higher score. But we also found that a lot of patients who said they had no problems eating had 4 or 5 of these symptoms. When you put those together, that's an impactful thing. The other aspect is almost all of these, nausea, vomiting, constipation, diarrhea, mouth sores, dry mouth, pain, everything other than the bottom ones, we have ways we can intervene with that. So if we have those patients identify what the problems are, then we can actually absolutely intervene with them. So although 60% of them reported no problems eating, over half of those had at least one and up to 5 or 6 other ones that they just weren't thinking about as eating problems. What's interesting is we think we're asking a question to get the data we want, but either we're not asking the question we think we're asking, or more importantly, the patients aren't hearing the question that we think we're asking. Now in terms of the ECOG status, again, surgeon, don't reinvent the wheel, take the same numbers you've done before. So again, 0 through 4. 0 is normal in terms of functional status, 4 is bedridden, and 1, 2, and 3 are fairly normal, less than half of the time in better chair, or more than half of the time in better chair. The interesting thing is also some places use a Karnofsky status. I personally can't keep those straight. There's too big a numbers. So, but at least you now know the comparison between the two of them. And again, we had patients about, here almost 20% of people who were spending more than half of their time in better chair. What happens if you're spending time in better chair? You have disuse atrophy. So not only do you have the nutritional, decreased intake, etc., but you have a thing that's a cycle, that if I'm spending time in bed, I lose muscle. If I'm not exercising, I lose muscle. If I lose muscle, I'm more fatigued. If I'm more fatigued, I can't. So it becomes a real cascade. So in terms of the clinical assessment, now that all of the stuff that I just mentioned was really those first 4 boxes: the short form, the abridged PG-SGA, the patient-generated component of it. The raters in the, it almost sounds like the Raiders of the Lost Ark, but the raters of the clinicians, about half were dietitians, 40% were nurses. So 92% of the people who were part of this were actually nurses or dietitians. And I actually think nutrition is a great place for partnering between nurses and dietitians, because patients lots of times talk much more honestly with those two groups than sometimes they do with the clinician, the physician. The weight loss. I'm going to say one thing about this. The other things are pretty much straightforward and obvious. But everything that is done in the patient version, the scores are very easy. Our Access is the only place, if you're doing the paper version, where you actually have to calculate something. But importantly, and it's on the first box on the worksheet on the back, to determine the score, you use the 1-month version data, if that's available, because we asked about 6 months and 1 month. You use the 1 month because that tells you not what happened a long time ago. But again, say if you as a dietitian saw them 2 months ago, and now they're starting to come up. You don't want to go with what was going on a long time ago. You want to go with the near chronic. You also take a component of what's happened in the last 2 weeks. Because again, that tells you anabolically or catabolically what's going on in that patient right now. It's a snapshot. And then what you do is you take that amount of weight in the 1 month, for example, plus the 1 point if they continue to lose for the 2 weeks, and then they can have a total score here of, say they had lost a lot of weight here, 4 points here, the 1 point for the 2 weeks, and they can have a maximum of 5 points there. Then we take the second worksheet, and that includes their disease state, etc. Now, as I'm getting closer, I still have a ways to go, but as I get closer to 65 years, do you think that that's a medical condition? I certainly don't. But the reality is that it is a risk factor. Geriatrics, people over 65, that's how it's defined in the States, people over 65 are geriatric. And when we looked at our data, those were the people who lots of times said, I'm not taking very little of anything. So it has something to do with their underlying risk factor in addition. So we put them as a kind of a surrogate marker there. Metabolic stress or metabolic demand. Whether or not somebody's having a fever, how high that fever is, how long they've had that fever, and also an important one that people tend to forget a lot is corticosteroids. You can have a significant effect in terms of muscle protein breakdown by the amount of steroids that people are on. And so that combined with these two plus bed rest, you can have patients who can lose easily more than 4 to 5% of their muscle mass per week. So those are important components. Physical exam. How many of you have seen or used or read about the PG-SGA before this talk? Okay. Now if you look at the back form of that, it's scary as all get out. Most people who see that go, I have to, it's like in a restaurant, I have to do this from this column and this. That's very scary. Now, when we originally designed it, we didn't have that. But think back 20 years. We're dietitians. Some of you are too young to know this. Some of us are more my age, perhaps. But 20 years ago, dietitians didn't do physical exams. I think our form was probably some of the stimulus of that because we were working with the American Dietetics Association and with MASS and doing that component. Now, you don't need to necessarily have all of those things. It's a global assessment. So it's really addressing what's happening to muscle, fat, and fluid status. So if this scares you, it scares me. Don't worry about it. It's much easier. To assess the muscle function or the muscle status, you're looking at muscle mass massive tone. And these are just examples of where to look. If you see somebody who's got massive muscle loss in their quadriceps, their thighs, okay, you don't need to do all of those other ones. It's really the global component. To do fat storage, you can look around the eyes, you can look at the triceps skin fold, you can look at particularly the fat overlying the lower ribs. You don't have to do all of them, okay? The other thing that's important and makes it much less intimidating is the total physical exam is only 3 points. So are you going to get someone who's mild versus severe confused? Probably not. It's going to be the 1 point difference between the mild moderate or the moderate to severe. And I teasingly say, even if we had something to drink at lunch and you had 2 glasses instead of 1, and we wouldn't do it to a patient, but we had you check another clinician and you were wrong by 1 point, would it make any difference? No. So it's making you look at things, but you shouldn't be intimidated by the physical exam because it's really that global component. Is it good to know how to do all those things? Absolutely yes. But in a busy clinical situation, it's more the global component that's important. Fluid status, obviously, somebody who you're wanting to gain weight, and they've got ankle edema, they've got ascites, they've got presacral edema, that can make a difference.